Sir, my question to all the members, I have few patients who are coming with CTV at birth, but after subsequent examination, we found that they are having cerebral palsy too. During birth, some issues, then it's cerebral palsy. So, do you suggest any kind of modification in the treatment or bracing in those patients?
So, about palsy is not the topic of clubfoot, you see. So,
I think what you're talking about, I think what you're talking about, the baby which was presented with a club fit, but there is some associated neonatal kind of maybe prematurity or other instances. And then they develop. So naturally you have to go according to first by the paucity only. I don't know whether, and then you can, because cerebral palsy requires a prolonged treatment, isn't it? All physiotherapy and everything. But first
I'm asking any modification in the treatment of clubfoot, because I found those patients, if they are being treated with tenotomy, they are becoming quite flail, they are not very happy. And the second thing is that the adductors are very tight. So if you are giving the routine Syndromic brace, which is available with the Cure clubfoot, then the knee is getting valgus. So that's why I'm asking, is there many experience or is there any...
Dr. MOSCA, you want to answer?
I'm sorry, I'm just missing this whole conversation. I don't understand your question.
Say clubfoot with concomitant cerebral palsy.
I don't have an ear for this.
Yeah. I think, what I personally feel, you have to explain the parent that these are the two total different entities, you know. I mean, you can't treat them both simultaneously and you can't have the excellent outcome. So I think the outcome of CP is totally different. So what your practical questions are, I fully agree with you. Okay. But I think you have to go by both the treatment of differently for the both techniques, right? Any question, further question, Dr. Cherry? Because we have to move further. We are
mine is to Viraj and Vikas. Yeah. So you've been treating with relapse club feet with modified Ponseti method and dorsal wedge osteotomy. The problem with these previously operated club feet is the correction of equinus. Even after you do the posterior capsulotomy, you won't get the equinus correction, the hindfoot equinus. So what do you do about that?
I mainly prefer Ponseti, those who are not operated, the virgin feet. Usually these operated feet are much stiffer as compared to the untreated feet. In case of operated feet, at times we have to do formal posterior release, followed by serial casting, along with the tendo-Achilles lengthening. And maybe we have cases also where we are using other modalities other than Ponseti in these operated feet. So I won't say that Ponseti is panacea for every kind of neglected club feet.
Viraj, what about this thing? How do you handle that?
Chiri, what I do, the same incision what we take for the tenotomy, we just extend that incision say around 2 centimeters like that, and with experience you come to that, from that incision you are very well able to release the posterior capsule as well as the subtalar joint. And if you see, most of these cases which has been operated by some of your colleague or like in the past, it is basically either the improper tenotomy or the non-releases of the posterior capsule which has caused the recurrence. So if you release by the same small incision, if you extend, I think it is very well corrected. Even sometimes the varus sometimes is a big, if the tissues are very tight. So if you release that, you get a correction of the varus as well.
Yeah. Two quick questions. In a premature child with low birth weight, how early do you start Ponseti treatment?
I'll take that one. There's no rush. Yeah, there's no rush. I never cast children in the ICU. There's no rush.
So, is the weight your criteria or number of days is your criteria?
The thing is, the most important thing is the child's health, not the club foot. If we can treat club feet starting at age 10 and 12, we could certainly wait a few months and make sure the child lives to have the clubfoot treated. They need their heels for blood draws. They need their limbs to save their lives. So I never cast the children in the hospital. When they go home, I'll start casting. And studies have shown that even if you start at a few months of life, there's almost no noticeable difference in number of casts required. But again, it's first about the child and then about the clubfoot. Anybody else?
Yeah, I think it's true.
So I can tell something. In my experience, from the epidemiologic point of view, premature with clubfoot is very rare in our experience in France, you see. And so the more premature is a baby, and the more flexible is the foot, because it spends a short time inside the intrauterine life, you see. So if you see a premature at 6-7 months, the clubfoot usually is not stiff, you see. Maybe it's non-idiopathic clubfoot as arthrohypotic, but if you are dealing with idiopathic clubfoot, usually is flexible. So there is no rush to do the treatment.
Okay. Next question to Dr. MOSCA. You showed the case of arthrogryposis where the knee was also stiff. So how did you manage, knee first or the foot first?
Well, simultaneously, put the cast on the foot up to the knee, identify the direction of the knee flexion, and then gradually flex the knee down. The child has an external rotational deformity at the hip, and just the weight of the cast will often give you the ability to internally rotate the hip joint, which I think in that case was dislocated. But anyway, you just have to know where the knee is and gradually start bringing the knee into flexion in the proper plane while you're casting the foot. I think that
we have to start the cases because it was only...
Yeah, so we wanted to show some cases for discussion, and so we'll get right to that. I want to talk about this child. This is actually one of my patients. And I've had several kids like this who have amniotic band syndrome and have a club foot. So what do you do first? Do you treat the club foot or release the bands at first? Dr. Shingati?
Yeah, I feel, see, the amniotic band has a different pathology. And it is one of the structure which can hamper even the neurovascular, particularly the vascularity hampering can be there if you try to stretch the foot with the band in situ. So my preference would be to release the band first and then manage the clubfoot.
Anybody else have thoughts on that?
Yeah, the bands seem to be very deep actually. If you try to correct the clubfoot, probably will have the lymphatic obstruction and probably more swelling. So it's preferable to release the bands by Z-plasty, followed by clubfoot ponseti management.
Anna?
I completely agree with this. You start by plastic surgery, and after you switch for the ponseti method. In France, we have less and less amniotic band disease. I don't know why, but there is a tendency for strong diminution of amniotic disease in our country.
Yeah, I've actually had 2 kids in the last year. It's pretty common still in the U.S. I'm not sure why. This might be random, but so yeah, these kids, they have it looks like a club foot, right? With amniotic band, it can look like a club foot or not look like a club foot. It could be partially formed, fully formed. It may not have ever been really a club foot. It just became one because of the banding. So you look at the foot and you say, is there a single posterior crease? Is there an empty heel pad sign? Those would be indications that the equinocablevarus foot really was genetically programmed to be a club foot, and then there was the environmental problem of the amniotic band. Again, the other way, it doesn't look like it would have been a club foot because it has normal posterior creases, you can feel the calcaneus in the back, but it's equinocablevarus because of the banding. So we all have agreed now that it's best to release the band. I usually tell the families, we'll try one cast, and if there's any swelling or obstruction, we'll take it off. And every time I've done that, within 2 days, the family calls and we take the cast off. Because no matter how gentle you are with the casting, there's some swelling associated with your manipulation. And the swelling can't go upstream. It can't get through the banding. So you take a break, and then you have to decide. I don't do the releases. I have partners who, hand surgeons and vascular surgeons, so they do the releases. They usually wait till about age 3 months. And so to the person who was asking about how long do you wait? Well, the most important thing is having a viable foot. So I'll wait until they feel they're safe, releasing the bands, and that was what happened here. These are the bands. This is about age 3 months. and then we went through the casting, and this was ready before the tenotomy, and here's 18 months later. So the child had the typical Ponseti. I think we did about 5 serial casts, percutaneous tenotomy, and then have been bracing. So this is an approach to, do many of you see amniotic bands here with club feet? A few, yeah. The alternative, just to move on from my case and get to the ones I think you might see more commonly, this is the other one. This is a malform. I'm sorry? Oh, yeah, that was a good question. My partners do it in 1 stage. Yeah, and they've been, when I was training, we used to do it in 2, but they do it in 1. Is there a way to turn that light down? I'm blind. And so this is the other, this is a malformation. This looks sort of like a clubfoot, but it's not the amniotic band. But even here, I just want to make the point that even here, I wait for the band release. The worst thing would be to do the Syme amputation and then close the skin and find that there was no perfusion going back. So even on the Syme amputations, I'll do the band release, make sure that there's good perfusion, and then have a successful Syme amputation for this malformed foot. All right, here's case number 3, and this is from Dr. Shingadi. I'll read it, or you can read along. 13-year-old child, arthrogryposis multiplex congenita, bilateral arthropathic club feet, operated at the age of 2 years with a PMR. So this was done elsewhere. Is that correct, Dr. Shingadi? It was operated elsewhere?
He was a child who was coming from Nigeria. So first he was operated the PMR at the age of 2 years. Then somebody did Elizaro after 5 years, and then again at the age of 8 years, again somebody has tried a PMR. So
this is after 2 releases, 2 extensive releases, and even in Ilizarov.
Very rigid fit, very rigid fit, very rigid, absolutely like a stone, you know.
And 13 years old, and lives in a remote area, correct? Like real remote, like nobody nearby. Okay, so let's see if Dr. Gupta, what would your approach be to this?
Yeah, the foot seems very stiff and had earlier surgery. So my take would be going for external fixator, which I have been using in these cases with good results, especially the Elizaro, and especially the correction through the bone using a distraction osteotomy, the V osteotomy, so that you can correct the both hind foot as well as the forefoot. Yeah.
So your osteotomy, so you do osteotomies. Would you do any preliminary treatment?
Yeah, preliminary soft tissue release prior to the osteotomy during the same sitting. Yeah.
So you do it in 2 stages?
No, in the same sitting.
Soft tissue release, medial side, posterior?
Like depending on the case, like if there's a cavus deformity, I will do the cavus release along with the TL lengthening, and then I will do the frame mount. Then I'll do the V osteotomy, and followed by the mounting of the frame, all in the same sitting. Yeah.
Okay. Is there a role for talectomy here? Ella, do you think there's a role for talectomy in this foot, double operated, Elizarov?
Talectomy is an option. So I have no experience with the talectomy.
What would be the upper age for a talectomy? This child's 13, lots of scar tissue, tons of scar tissue. What's the upper age for a talectomy?
Dr. MOSCA, do you feel that after talectomy, the forefoot adduction is corrected to a great extent? Because there are many literature which suggests that, the forefoot, particularly the adduction, still persists even after talectomies. I don't know. Dr. DiMeglio, would you?
The strategy is always the same. You need to find room to correct the foot. Maybe you can do, when you are doing the surgery, you have to have in your pocket many strategies. You can do talectomy if you have some difficulties by conventional osteotomy to correct the foot, or you can do salvage procedure. But you have only one things that you have to take in mind, that after many surgery, you can run the risk of ischemia. So in my experience, I like very much to do arteriogram before, you see, because after 5 or 7, 6, 7 posterior meningeal release surgery, you are not sure that you have a good vascularization of the foot.
Okay, so, and I think, let me just, get to the microphone. So the one point is, at this point, soft tissue release isn't going to work, right? You can either lengthen soft tissue or shorten bone. And clearly the principle here is soft tissue releases ×2 and soft tissue stretching ×1 haven't worked. So we have to do a bony approach. And I guess the only other question I'd say is it feasible to do everything at once, or would it be better to do some soft tissue release or stretching again and then do the bony shortening procedure? So a lot of that has to do with where the child lives, what the resources are, and in most cases this type of foot is not in a resource high area, so it should be one and done. What was your comment?
I am Dr. Bari from Bangladesh, Dhaka. And considering your case, you have not shown the last X-ray. Can you show the last X-ray? And considering the age of the patient is running 13 years, he has done several times surgery, including the Elizarov. And my comment is here, if you go for Elizarov surgery, you can correct fantastically all kinds of deformities, rigidity, everything. But to put the Elizarov in proper way is very important. Otherwise, no other options, including the Ponseti, operative surgery, and any other options will not run for this case. Elizarov surgery, considering the age of the patients, and you have done the several times surgery here, so no other good options except Elizarov.
But it has been already performed. The Elizarov has been already done.
No. I told you that properly application of the Elizarov is very important. Elizarov done, that is okay. But who has done?
Is Elizarov will only suffice, or you would add some osteotomies, like Vikas has said?
Osteotomy, considering, you see, up to the 15 years, I have not learned that from the Kurgan Center that you go for osteotomy. Up to 15 years, you don't need to go for osteotomy. That what I am doing all the time without osteotomy, gradually, differential distraction, by controlled coordinated stretching, you can correct this kind of deformity.
I think I completely disagree with this, because I think every case is different. What happens, being a surgeon, we feel that this is the best and we always try to apply same for all cases. I think there...
So I think it's good to agree to disagree here. We don't know, or we haven't heard, if the first Ponseti method was a soft tissue stretch and then no maintenance bracing, or if the first procedure was osteotomy. More likely than not, Dr. Shingati, was the first one soft tissue stretch alone, no osteotomies? Is that correct?
Yeah, but the issue is, I think these are the cases where whatever I don't know, Vikas will agree with me or no. I had a discussion with Penny and Herzenberg that I asked them that whether really the unlocking of the talus and calcaneum happens when we talk about these kind of deformities, and they have no answers. It is my proposal that in such type of cases, when we try to apply the Ponseti, it is a crushing of the fit you are creating, because there's so many tightness in the structures, isn't it? When you try to the final correction, I think it's a crushing of the bone. So why not do the osteotomy? I mean, what is the? I mean, no for the osteotomy.
Yeah. So there again, I want to get more to the principles that is done in each of these cases. And I'll be the first to admit, I don't see these cases, except at conferences. So I'm happy to discuss different options. Elizarov method is, I visited Kurgan in 1989, in September 1989. Spent 2 weeks there. I was the first American group, to learn the foot frames from the man. And I went home, didn't really see enough indications for them in my part of the world. So I sort of lost the techniques. But Elizarov is powerful, and you obviously have experience with it, and you're talking about the osteotomy type of Elizarov, which is certainly more permanent than the soft tissue Elizarov procedures. I tried some of those when I got back to Seattle in the early 90s, and boy, I could correct them really powerfully. I couldn't maintain them. But some people could do a better job at it than I could. Like I said, I just don't have to do them anymore. So Elizarov is certainly an approach. Osteotomies are a certain approach. What's clear is that you don't want to be the fourth in doing soft tissue surgery on a 13-year-old with recurrent club foot. And so my question to you would be, if you do a midfoot wedge resection, that clearly takes care of cavus and adductus, but it has no effect on the subtalar joint. You're distal to the subtalar joint. So, and I was trying to look at the photographs of your patients because they weren't in much equinus. They were primarily cavus, supination, adductus, but and some varus, but they weren't in much equinus. So I could understand cutting the tendon Achilles, and the tails would probably be okay in the ankle mortis. But if you do a wedge resection of the midfoot, you still have the navicular that's too far medial. And how do you deal with that?
That's the same what a technique I had described, that I cut the plantar fascia, and then from the posterior incision I do the tenotomy plus posterior ankle capsule. Particularly this case, the indication, even what Cherry has asked me the question, these are the cases where you need to release in addition to the tenotomy, from the same incision I release the posterior capsule as well as the subtalar release, and that gives a very good correction. I think we can see the subsequent, what was done in this particular case. We have a couple of slides, so maybe...
So I was wondering, if you did the midfoot, let's say you said, all right, I'm going to do a midfoot wedge resection. I'm going to not only take a wedge, but take a trapezoid out. Then I'm sure I've got the cavus corrected, I've got the adductus corrected. There's still hindfoot varus. Would your backup plan ever be then to add a posterior calcaneus translational osteotomy? Because I could see that as the salvage. You do the midfoot and everything looks really good, but there's still a lot of hindfoot varus. You don't want to you couldn't even find the subtalar joint if you tried. But there's still hindfoot varus. So you've done your midfoot resection, you love the midfoot, you love the forefoot, there's too much hindfoot varus. So you can just cut the posterior calcaneus and slide it over, and then it's a stiff, compensated foot deformity. Yes?
Yeah, I fully agree.
Okay. Any other comments or questions?
Sure. I can make a comment. Whatever you do, what surgery you will do, you cannot guarantee to the family that the foot will be painless and functional. And so you must have a clear discussion with the family because it's a very risky surgery and the functional benefit is not sure.
Oh, and let me ask this doctor here. I'm sorry, I forgot your name. But when these children come, and Dr. Shingati was saying this child comes from far away, they're very poor, they have to do the operation and they have to go home. So once they're in a frame, they have to be with you for a while, right? How long do they have to stay with you? How long do the doctors in the frame stay in your center? Right, but did they go home to their home?
You just primarily 1 to 2 months, you just keep the patient under your strict observation, and then you can tell your patient to come to your place after 2 weeks or 3 weeks or 1 month.
Yeah.
And that must be followed up strictly.
Yeah, so that's obviously an important consideration. I have a lot of friends in the U.S. who go to other countries, often in Central America, and they go for a week every summer or whenever they can get away. And sometimes they go to Vietnam, and they have to do everything in that week, and then they're out of there. What's your comment?
I'm Jerry Nag. I'm from Liverpool. We do have to treat some difficult deformities, and I think it's very important to recognize that the soft tissues here are heavily scarred. And any major acute corrections, even with trapezoidal wedges, you really don't know until you do the surgery if you're going to get away with the soft tissues, and that's important to recognize. The Elizaroff method is gradual. It's really Ponseti on steroids. And I think, in some of these cases, we've used the Elizaroff to get the overall correction, and it takes about 10 weeks to do that. And then you take the frame off and go in and do a triple arthrodesis. You solve your soft tissue problems. You don't have that worry of the soft tissues breaking down. And you have a foot that's nearly corrected, making the triple arthrodesis a lot simpler.
So you use the Ilizarv to achieve correction, knowing that it's not going to be maintained until you do the maintenance procedure, which is
a triple
frame off, fuse.
And so the child would need to be with you for about 2.5, 3 months.
Right. So again, it's not I'm just going to go there and do my humanitarian work for a week. Anybody else? Okay. Let's just show this one through here because we have all the. So what was performed by Dr. Shingati was a plantar fasciotomy, tenotomy, dorsal wedge, the operation he showed earlier, casted, and here you see the child. Was this the child that you showed us earlier, Dr. Shingati? Was this in your... So here's a 3-year-old girl. This is another case of a 3-year-old girl. Unless there are any other comments on that one? Okay. 3-year-old girl decided to go for the Ponseti method. Never treated before. And then there was recurrence. So she's 6. At age 3, she came for her first management and had the Ponseti method. It worked well, wasn't maintained, perhaps not because of not bracing or muscle imbalance. So she's 6 years old. Alan, what do you do in the 6-year-old with the basically untreated or severely recurrent clubfoot?
Usually I start always, I told you, by plaster, step by step. You see if I can gain some reducibility also to improve the skin, you see. And after, if I can progress, it's okay. I stop. If there is stagnation, I continue by mini incision to cut and to combine plaster. And at the end, if I cannot have a control of the foot, I go for surgery à la carte. And I like very much to go first on the posterior area and to lengthen the tendon, to decrease the tension around the foot by lengthening at the red and white portion, the tendon, as in cerebral palsy, fractional lengthening. This decreases substantially the posterior hindfoot, and after, step by step, I used to go first on the lateral part to decrease the tension on the medial part. So you have a good approach if you go first on the lateral approach.
So Dr. Gupta, how old is too old to consider casting? Maybe that already came out this morning, but for you, how old is too old to initiate Ponseti casting?
Actually, very difficult to answer. With actually Ponseti, the upper age limit is increasing. But my oldest case was 11-year-old, which I showed you. So I feel the age is not a criteria. The important is the flexibility. In spite of the negligence, most of the cases do have the correctability. So I don't take age as the determinant. Like regarding this case, like she is 6, and what I can see, seeing the picture, that she has a global relapse pattern, both hindfoot as well as the forefoot. So I would go for Ponseti again, and probably would be able to correct all the deformities. But I would like to add the tibialis anterior tendon transfer in these cases.
So what's your reason for doing the tendon transfer?
To prevent, moreover it acts like a dynamic splint and prevents further relapse. Balances the muscle forces. She might be having an element of dynamic supination.
All right, so we know that perhaps up to 35 to 40% of kids with clubfoot have muscle imbalance. Those who are treated right from birth, they have 6 casts, they have a tenotomy, they do the bracing. We know that from the research, at least 35% of them need a tendon transfer. In fact, the group reported in 1995 by Cooper and Dietz of Ponseti's patients who were now 34 years old, 50% of them had a TA transfer, 50%. So now we're seeing less of them, maybe because we're casting them longer, or we're bracing them longer. Who knows why? Maybe the genetics has changed, but some feet just have a weak peroneus brevis and tertius. So the tendon transfer. But tendon transfers don't correct deformity. Now, muscle imbalance leads to deformity, but moving the tendon, number one, doesn't correct deformity. It will balance the forefoot, midfoot, but it's not going to do anything to maintain flexibility of the ankle. That's, again, that's completely unrelated. If the child has recurrent equinus, that's not from muscle imbalance. If they have repeat inversion and supination, that's muscle imbalance. But if they're coming back in equinus, that has nothing to do with the tibant. So you want to achieve deformity correction and say, this is an older child, maybe the recurrence is due to muscle imbalance, so I'll correct the deformity, minimally invasive a la carte, and then do the tendon transfer to balance what I can balance, knowing that there still might be a possibility of recurrent equinus because that's independent of the tendon transfer. Yes, question.
I think these type of feet, which have recurred following a conservative treatment, they do very well with the Ponseti method. We have experience of more than 100 feet treated by Ponseti method up to the age of 11 years plus.
11, okay.
Yeah. And we feel the feet which have sufficient remodeling potential left, around 10 years in a female, around 11 years in a male, they do very well with the Ponseti method, with little modifications, of course. The problem in Ponseti is there is a very, very stubborn cavus deformity. Plus, using a brace in a walking child, it is very difficult to give a child a brace for 3 months in a walking child who has been treated. So we have modified those things.
How does a brace help? How does a brace help for the cavus?
No, not for the cavus. I'm talking of the Ponseti method. Cavus is very, very stubborn in these feet, so cavus has to be treated differently. Dr. Vikas had told a wonderful method of a percutaneous fasciotomy. We correct cavus and adduction together so that we reduce the number of the casts. And we don't give braces for full time for 3 months in a walking child. We put the child on a walking cast, below knee walking cast, so that it is walking and doing everything. Otherwise, in a child more than 1 year who has already been walking, putting the child in a brace is terrible.
But here the Ponseti has already been done, you know. I mean, it was extended
So
Ponseti,
this I'm saying, the
still
feet-
recurred, and we give the corrective plasters also after that. If you see the clinical photographs, can I just go back, Professor MOSCA, if you see? Go back. So there is a big torsion, you know, in the tibia. So many times what happens, we just concentrate on the foot. If you see if you see the knee joint, you know, it is on the absolutely lateral aspect, and if you see there is a big amount of torsion in the tibia.
Yes,
So I think that is the purpose of putting this case, that those kind of reverse feet, it is not like that only the fit. There could be the other associated problems you need to tackle.
I fully agree with you. If there is a other problem like torsion, this have to be tackled differently. Like one of the persons, Dr. Sudhir asked a question, cerebral palsy with CTV. So they both have to be tackled. You have to alter the brace in those cases. In cerebral palsy, when there is adduction deformity, when there is adduction contracture or a deformity, you cannot keep a brace with a bar up to the width of the shoulders. You have to rectify that. You have to take care of the adduction at the same time. Similarly, in patients which are treated by Ponseti, in our country, there are so many children who have rickets. If you continue using brace, the child already having rickets, I have found children developing external tibial torsion. So these things have to be taken. Otherwise, if there is no other torsional deformity, foot which has been treated conservatively do very well with a repeat Ponseti. That I wanted to say.
Okay, there you have it. So here's what was done. Left foot osteotomy, I think the way we saw it before, external rotation of tibia and fibula, and here's the follow-up. And then the right side was done. And what was the reason for the tibial rotational osteotomy?
Yeah, I think, see, we are already tied for the Ponseti, and on table when I did even the foot, which was not correct, so the tibia was the main another culprit, you know, so I had to external rotate the tibia to get the correction, and now it's almost 8-year follow-up. I think we have to judge on table also many things, that you should be prepared, not that every correction at the foot is going to give the, so many times the torsion which is there, which is not corrected by any other, you have to go it for the external rotation osteotomy for the tibia. I don't know whether you agree or no.
If my experience has been that the tibia is rarely abnormally rotated in a child with a clubfoot. I think the tibia is right. I think you can create tibial deformity by inappropriate casting where the talus rotates the fibula posteriorly. So you can create external tibial torsion that isn't there in the first place by inappropriate casting. But however it gets there, whether it's idiopathic external rotation or it's created by the casting, one will perhaps need a tibial rotational osteotomy if there's deformity left in the subtalar joint. Right? The subtalar joint is a rotational joint. So if you leave some inversion in the subtalar joint, inversion being internal rotation and plantar flexion under the talus, and you don't completely correct the subtalar joint, there will appear to be internal tibial torsion, even though it's internal rotation of the subtalar joint. So you correct the subtalar joint the best you can, and if you make it anatomic, you can assess the tibia. But if you leave any inversion, which is internal rotation, in the subtalar joint, then the intowing will be from the subtalar joint, not from the tibia. But if you can't operate anymore in the subtalar joint, then you create a deformity in the tibia to compensate for what you can't correct in the subtalar joint. So just remember, subtalar joint is a rotational joint, not just an up and down joint. Anyway, it looks great, and she looks comfortable, and things are moving except for her midfoot bones. Well, we have 36 seconds left, so we'll take any other questions on these two cases. So like I said, I don't think it was that important to talk about exactly what was done, although the results look fantastic, but more to talk about the principles of management of these complex feet. So any final comments or questions? Yes.
What is yours, Dr. Kiran Patel from Anand, what is your say about tibialis anterior transfer in a primary surgery of CTV? And does it help recurrence or any way it supplement the procedure after failed Ponseti or while doing posterior medial release of tibialis anterior transfer to second or third cuneiform or to prevent dynamic supination or whatever?
I don't know, I'm having such a hard time with the...
Yeah, Dr. MOSCA, there's only one case. We have only 2 minutes because we have to... Yeah, so... It's the last 2 minutes we have because there's a appeal from the organizer.
Our time is up. All right, well.
They have to start a new session, so last case, 2 minutes only.
So this is a 12-year-old boy with a clubfoot. Actually, he had an unsuccessful posterior release at the age 5. So now you can see he walks on a dorsolateral border, painful gait, unable to play outdoor games. And he has a hindfoot varus equinus with midfoot cavus and adduction. The X-ray will show the bony changes, subluxation of talonavicular joint. And what is important to see, that subtalar joint is non-congruent, arthritic. So what are the options? I'll go fast. Now, Ponseti, how many of you would like to go for Ponseti? Show of hands. So Ponseti is an option, and I had a talk on Ponseti, but the foot is stiff. There are changes in the subtalar joint, along with bony changes. So highly unlikely that Ponseti would work alone. Then you have the extensive soft tissue releases. He already had posterior medial release. So any further soft tissue release would add to the, probably will lead to neurovascular damage to the collaterals. Then osteotomy is an excellent lecture by Viraj, but probably they will require multiple osteotomies, one for the hindfoot, another for the midfoot, and would lead to further shortening. So you have the options like Indian version of Elizero, Jess, and finally the Elizero gold standard. So what I did, my plan was using an Elizero with a distraction osteotomy. We have different kinds, supramellar, V or U. Those who are doing regularly Elizero may be knowing. So the indication for the osteotomy are basically in an older child, more than 8, the foot is fully developed. Incongruent joints, stiff joint is another indication, and presence of previous surgeries like fusions. So the procedure was initial soft tissue release, especially the plantar fascia release, TL lengthening, followed by this V osteotomy. Now it's a special osteotomy, double oblique osteotomy, indicated for a stiff subtalar joint, anterior calcaneotalar limb, which passes through the talar neck, and the posterior calcaneum limb. And they converge on the plantar aspect. So what is important is that distraction occurs through this osteotomy. So frame mounting, the principal tibial ring, tibial mounting using 4 rods, connected through 4 rods, and connected to the calcaneum half ring with mediolateral hinges and posterior distractor. The important thing is the calcaneum half ring should be positioned to mimic the hindfoot deformity, equinus and varus, and the metatarsal half ring. Now, once you have done the frame mounting, what is important is to appropriate connections and hinges to correct all the deformities simultaneously, not consecutively. So, correcting the forefoot and the midfoot, remember, not through the soft tissues, but at the pivot point, that is the calcaneo-talar osteotomy, which acts like a virtual joint. You can see that in the picture, that how does it correct? So, there is a gradual and differential distraction. The child can weight bear during the process, and it needs a periodic adjustment. So there was a good correction. You can see the video. It is now plantigrade, painless, and the foot length is not sacrificed. So to conclude, the advantages of Elizero, you all know that multiple foot deformities are not corrected consecutively, but rather simultaneously. The magnitude of deformity is not a barrier, because the Elizero is based on the principle of bone regeneration rather than bone resection, which you do in osteotomies. And since no length is sacrificed, deformity correction, the foot is not shortened. But disadvantages are similar to any other fixator, pin track problems. It's a complex frame, lengthy treatment time, and the last important line is, which the parents and the child should understand, that even after correction, a stiff equinovarus foot, though corrected into plantigrade, still remains a stiff plantigrade foot. So at times, the child may not be satisfied, but it definitely becomes a plantigrade and shoeable. Okay? Thank you. So any questions or comments?